All right, so last quarter in kinesiology, we talked about the different classification of joints and the movement of joints. Now we're going to talk about the pathophysiology of joints, or the articular system. There are some of these pathologies we encounter again and again in the clinic, and some of them we might never see. So let's talk about them. Same learning objectives for chapter 8 that we saw in the bone trauma section. So traumatic injuries, when we have bones coming together, we have joints, and in the joints, we have tendons, ligaments, joint capsules, articular cartilage, all that great stuff. So when we're talking about sprains and strains, we're talking about ligament or muscle and tendon injuries. So remember, ligaments are the strapping tape that limit motion, and tendons transmit motion from muscles to bones. So a sprain is a ligament injury. So it can be anywhere from just a little bit overstretch of the ligament to a complete tear. Common sites for sprains are ankles or wrists, sometimes knees. They're usually accompanied by swelling. Swelling can be either effusion, which is swelling inside the joint, or edema, which is swelling outside the joint. Strains, on the other hand, are muscle or tendon injuries, and they can be either acute, like sudden trauma, or chronic, like overuse injuries, tendonitis. Common sites, low back, hamstrings, Achilles, elbows, really commonplace for tendonitis. Lots of tendonitis showing up in the clinic. So sprains have a classification system, mild, moderate, and severe. First, second, or third grade or degree sprain. So you'll hear a first degree sprain. The level of tissue damage is generally how they classify sprains. Because both tendons and ligaments are soft tissue, they don't show up on x-rays. And so in order to use imaging to diagnose a sprain or a strain, you have to get an MRI. That's the only thing that's going to show up. However, they don't usually go straight to an MRI. Usually they will do some clinical assessment to figure out how much instability there is in the joint and assess the degree of the sprain from that. And there are a lot of special tests that you'll learn in your orthopedics class. So a first degree or a grade 1 sprain, there's little tearing of the ligaments, mild pain, minimal dysfunction, and we're going to treat it with rice and early mobility, because mobility equals circulation and circulation equals healing, right? So we'll talk more in other classes about the timeline for these things, but the less circulation a tissue has, the longer it's going to take to heal. So ligaments don't have great circulation, so they take a little longer to heal. And depending on the degree of the sprain, they might take a pretty long time, like 10 to 12 weeks. A grade 2 or second degree sprain is moderate severity, a partial tear of the ligament, moderate pain, and some instability because of that partial tear. So protection and progressive rehabilitation. A third degree or grade 3 sprain is severe, is either a complete or near complete tear of the ligament. Severe dysfunction and instability may need surgery or long-term rehab. Because of the lack of circulation, it takes a long time to heal. And if the ends aren't together, it takes a longer time to heal. So grade 3 sprains are also or they cause a lot of instability in the joint. They might allow excessive joint motion. So there's that ligamentous instability that and you might get more arthrokinematic movement in the joint. So a really severe sprain untreated could lead to osteoarthritis later on in life. Strains have a different classification system just to make it interesting. First degree, second degree, third degree, from mildest to most severe. With a first degree strain, there's little tissue tearing, get mild tenderness, pain with full range of motion usually, and there's minimal dysfunction. With a second degree strain, you have a torn muscle or torn tendon tissues. It's painful, you have limited motion, you have restricted range of motion, and swelling, and sometimes you get a little bit of depression of the tissues at the injury site. In a third degree strain, it's either a complete or near complete tear of the tendon or muscle tissue, and it's severe. Um, Initially, the pain level is severe, but then sometimes it can be painless because you're not moving. You don't have that connection. So there's limited or no movement and significant functional loss because you can't move. So strains can produce extensive swelling and ecchymosis, which is that bleeding underneath the skin, and be potentially be painful or incapacitating. So strains can be um, really painful. And the good thing is, though, muscles have great blood supply and they heal fast. Tendons, a little less blood supply, don't heal quite as fast. But so depending on the degree of the strain, it can be pretty mild to pretty severe. Chronic conditions, so tendinopathy and tendonitis, what's the difference between the two? So tendonitis, as we know, itis is the word suffix for inflammation. So tendonitis usually indicates acute inflammation of a tendon. There's swelling, warmth, redness, the normal signs of inflammation. It generally heals in weeks and responds to rice and NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs, so ibuprofen. Um, we might do some supportive taping or some other things to help support the tendonitis. Tendinosis, on the other hand, osis is usually the suffix that means like condition of some sort. So there's chronic degeneration of the tendon. You might get crepitus, which is creaking or crackling noises at the joint, and lumps and bumps in the tendon. You can actually feel with your fingers, and you can feel them even more with instrument-assisted soft tissue mobilization. You can just feel all those little icky lumps and bumps in the tendon. It takes longer to heal, so months versus weeks, and generally needs long-term rehabilitation. So you need to correct faulty movement patterns. You need to lay down healthy tissue. It's a longer process. Bursitis is inflammation of the bursa at the joints. So again, it's an acute inflammatory disease. There's pain with movement. It's common in the shoulder, hip, and the knee, are joints that we put a lot of pressure on or have a lot of movement in. Similar treatment to tendonitis because it's an inflammation. The sometimes bursitis can be a little bit of what I call a garbage can diagnosis, where they go, "Well, we don't know what it is. It's probably bursitis." So, mm, I've definitely had people who had a diagnosis of bursitis, and they came in and really they had a muscle strain, and we worked around that. But anyway, similar treatment to tendonitis, and it's that acute inflammatory process. Muscle atrophy, it's the use it or lose it principle. If you're immobilized or you have some sort of injury or illness that's causing immobilization, you can lose muscle size, lose muscle strength, and increase the stiffness in the muscle and the surrounding connective tissue. Our role in muscle atrophy is early intervention and gradual progress. So we want to make sure that people don't get to that point. If they come to us with muscle atrophy, we're going to gradually progress them to get them stronger. The caution you need to have is that atrophied muscle damages more easily. It's not as strong in the power it can produce, and it's not as strong in the tension that it can take. So gradual progression is the key. For chronic conditions, in the acute phase, we're going to use the Rice-Price protocol, of course. During the recovery phase, we're going to go with progressive exercise. So we're going to go slowly and progress them as they can. The goals are to restore function and to prevent re-injury and focus on correct movement patterns. So particularly if they have a tendinosis or a bursitis, they might have it because of faulty movement patterns. And we want to correct those faulty movement patterns to prevent it from happening in the future. So arthritis, we see it so commonly in the clinic, all types of arthritis, really, but osteoarthritis particularly. Osteoarthritis is the wear and tear. It's the thing that a lot of us have, and that it's super gradual onset from years of jumping off cliffs on your skis or whatever you did to eventually wear your knee out. If you have posture um, deviations that can cause wear and tear over years. The pattern of onset for osteoarthritis is generally asymmetrical because you're only wearing out certain parts. You're not wearing out everything. A lot of times people with osteoarthritis have stiffness in the morning for about 30 minutes until they start to get moving. Common joints, hips and knees. Hip and knee replacement are the two most common elective surgeries in the United States, and you will see tons of hip and knee patients in whatever setting you work in physical therapy. Total knee arthroplasty and total hip arthroplasty. Hands are common areas because we're using them a lot. Your distal IP joints and your first carpometacarpal joint because we're using it for gripping. Spine is also a common area for osteoarthritis because yes, we are using it all the time and we're loading it all the time. For osteoarthritis, there are no systemic signs, so we don't have any fever or fatigue or any of the systemic signs. Rheumatoid arthritis, on the other hand, is not a wear and tear. It's not a mechanical issue. It's an autoimmune disorder. So the immune system attacks the joint capsules, basically, and the joint surfaces. It's gradual onset of weeks to months rather than years. The pattern's usually symmetrical or often symmetrical. So both hands, both feet, that sort of thing. Sometimes if it goes on too long, you can get significant deformities in joints. People with rheumatoid arthritis are also stiff when they get up in the morning, and they tend to have stiffness for greater than an hour. So more stiffness than osteoarthritis. The Arthritis Foundation recommends exercise for both. And we'll talk a little bit specifically about exercise for rheumatoid arthritis, but they actually recommend that you work through the stiffness, work through the pain. So it's not very often where we tell people to work through the pain, but with arthritis, yes. In rheumatoid arthritis, it's common in the hands, so the metacarpal phalangeal joints, the proximal IP joints, the wrists, and the feet. But it also certainly can affect other joints in the body. Rheumatoid arthritis, because it's an autoimmune disorder, does have systemic signs of fatigue, fever. Sometimes you get nodules in the joints that are palpable. Gout is it's considered to be a form of arthritis. It's uric acid crystals that build up in the joints. A lot of times, acute exacerbations of gout have sudden onset, so within hours. Usually affects one joint. A lot of times, it's the big toe. I've seen people with gout in their elbows. Ankles and knees can be an area too. They might have a fever during the attack, but not at other times. I went to a lecture from a rheumatologist about gout, and it was very interesting. They used to tell people to like don't eat liver or whatever, some gross stuff that people don't eat anymore. But they said now there are medications, long-term medications that can manage gout, and it's not really caused by what you eat. It can be exacerbated by what you eat, but it's caused by your own body chemistry. Some people are just more prone to gout. So it used to be thought that if you like eat a lot of meat and drink a lot of alcohol, you're going to get gout. But if you don't have the body chemistry to do it, it's not going to happen. So what you eat doesn't cause it, but what you eat can make it worse, if that makes sense. So the key features of osteoarthritis are the pain is worse with activity. And sometimes you get crepitus, which is like creaking and cracking in your joints, and sometimes bony enlargement where the joint becomes a little bit larger because it develops osteophytes. Remember, bone changes with the stresses we put on. If you have additional stresses, you might build up bone in those in different areas. So sometimes they're called Heberden's or Bouchard's nodes. Um, with rheumatoid arthritis, pain is worse with rest. That's why exercise is recommended because it's worse with rest. A lot of people that I've worked with RA love pool exercise. And OA, both of them love pool exercise. Who doesn't love pool exercise? You get particular deformities in your hands with RAs that have names like swan neck deformity and boutonniere deformities. You can see pictures of those in the book and kind of interesting. Ulnar drift, where the fingers go towards the ulnar side. And then, of course, there are systemic effects with rheumatoid arthritis. For osteoarthritis, our PT approaches low impact exercise, strengthening the periarticular muscles, weight management, because you don't want to put additional pressure on the joint, and joint protection. So some of our joint protection things might be using assistive devices or adjusting your the height of your chair and different things like that, so you're not putting stress on the joints. But one of the things that I've seen over and over again with people with osteoarthritis, they're afraid to move because it hurts when they move, and then they lose mobility. So I always encourage people, I say, you're not going to make it worse by moving. So move, because you are going to make it worse by not moving. And so even if it's painful, move your joint through the full range of motion, as full range of motion as you have. And I've talked to a lot of people. The patient education part of it is super important. Some people I've said, you're not going to make it worse by exercising. It hurts when you exercise, but do it anyway because it helps. And some people feel better that, like, oh, okay, it doesn't matter if it hurts, or not, it doesn't matter, but it's not going to hurt anything if I exercise. They feel better about it. But exercise is a great way to manage pain, and it's a great way to manage osteoarthritis. Rheumatoid arthritis, people tend to have flares and remissions, or exacerbations and remissions. So during a flare, you want to rest and do gentle range of motion, like in the pool is a great place to do gentle range of motion. During remission, you can work on progressive strengthening. When they're in the middle of a rheumatoid arthritis flare, you don't want to do progressive strengthening. You want to rest, maybe gentle range of motion. Energy conservation is important. And that's something we can educate people on, and avoiding forces that deform the joints. So we can talk about the person's individual activities and help them modify them to avoid those deforming forces. As we age, everybody, not just people with arthritis, our bone density after age 30 is decreasing. So whatever you did before age 30, that's like your savings account that you have to draw on for the rest of your life. So I'm glad I was jumping off of stuff and into stuff and over stuff before I was 30 to get bone density. As your bone density goes down, your fracture risk goes up. So the most vulnerable areas of your body, of your bones for fracture risk, are spine, hip, and wrist. The muscles tend to get smaller and weaker. It's called sarcopenia. The type 2 muscle fibers are most affected. So those are like our power muscles rather than our endurance muscles. So you have an increased fall risk and decreased function. The good news is that strengthening is possible at any age. It doesn't matter if you're 98, you can still work on muscle strengthening. So get out there and lift those weights or do body weight exercises. It doesn't matter. Strengthening is important and possible at any age. And as a good side benefit, strengthening your muscles helps your bones. So, I'm all about strengthening. So, PT, a lot of times people are referred to PT to manage age-related changes, which, good, send them in. We'll help them out. So the things that we need to know are prevention strategies. One of them is weight-bearing exercise. So some people think weight-bearing exercises means you have to lift actual weights, but what it means is you have weight on your bones. So walking is a weight-bearing exercise. So the walking, sometimes people say, well, I'm going to do swimming. And swimming is fine, but it's weight reduction. So you're better off walking in gravity if you can, but sometimes if you can't, walking in the water is a good substitute. Adequate nutritional intake of calcium and vitamin D and fall prevention is super important. The treatment modifications that we're going to do for age-related changes, it's going to be a slower progression. We're not going to progress really quickly. We're going to put some emphasis on joint protection and functional over strength gains. So what can you do with this strength that we're building? So functional gains are important. So a lot of times we will use functional outcome measures to measure our progress rather than things like manual muscle testing and actually looking at strength gain. So we're going to look at functional over strength. So our assessment priorities are proper injury grading. We're going to do something different if we have a grade 1 strain versus a grade 3. Acute versus chronic, we're going to have a different treatment approach for an acute problem versus a chronic problem. The type of arthritis, we're going to have a different treatment approach for osteoarthritis versus rheumatoid arthritis, and age-related considerations. So the older you get, the more important function becomes, even though it's important when you're young. But the treatment principles for acute injuries were Rice and Price, progressive rehabilitation, movement pattern correction, and joint production strategies. So the things that we want to look for as red flags is excessive pain with movement that doesn't stop when you stop the movement, signs of infection, so we know our signs of infection, neurological changes, so changes, signs of changes in sensation and that sort of thing, and unexpected functional decline. So if you're it's just all of a sudden someone has a big functional decline, that's a red flag, and there's something else usually going on, and usually it's something systemic, like an infection or some other type of disease. The things to remember is early intervention prevents atrophy. But we want to progress cautiously with previously injured tissues because remember, scar tissue doesn't take the place of the function of the other tissue. It just fills the holes. And so previously injured tissues are going to respond differently from never injured tissues. So tendonitis versus tendinosis, the treatment approach and the timeline differ significantly. So make sure you know what you're dealing with. Um, Rheumatoid arthritis flares require rest. We're not going to push through inflammatory episodes. We're going to rest during flares and we're going to strengthen during remission. During an acute gout attack, you want to avoid any pressure or aggressive treatment. So maybe somebody's coming in to see you for something else and they have an acute gout attack. You might have to modify their treatment during this short amount of time when they're in the middle of that acute attack. Always remember, older adults can strengthen. You never run out of the ability to strengthen. But you do want to focus over function rather. You don't want to get like, you know, huge muscles when you're old. You just want to be able to pick stuff up and open things and, not fall. Um, Education's really important. Prevention strategies, home program compliance. So I always like to say to people, hey, show me your home exercise program. Make sure they can do it on their own without you there. Because sure, they can do it with you there, but can they do it on their own? Are they doing it on their own? And if they're not, what are the barriers that are keeping them from doing it? Help them overcome those barriers. So remember, the articular system works as an integrated unit. You want to address the whole kinetic chain and not just like, oh, it's your knee, we're only going to strengthen the knee. No, you want to address the whole kinetic chain.